sum up what we've learned. So first of all, we have Professor Glenda Gray, who is the President and Chief Executive of the South African Medical Research Council. Then we have Sir Andy Pollard, Professor Pollard, Professor of Paediatric Infection and Immunity at the University of Oxford. And then Dr. Hannah Kettler, the Director for COVAX's Design and Operationalisation at Gavi. Thank you all so much. Right, okay, so we came into this, this meeting looking for answers, looking for hope, dare I suggest, after Sir John kicked us off by saying that actually it had been pandemic preparedness had left the political agenda with eye-watering speed, which perhaps wasn't the most hopeful message you could have given us, but it was a mission. So I'd like to start by asking each of you, you know, what you think that you've learned today, maybe things that we are making good progress on, and then also what you've come away with thinking what needs the most work. I'm going to go for you first, Glenda.
Okay, so we heard this morning about, George said that he named this the 3 C's, I think he said, collaboration, coordination, competition. I hope you said communication as well. But I'm going to add another C, and that's cash. You know, so we've all been very polite about the funding issues, and maybe it came up a little bit in the last session about the resources. So we need a cash cow for this, and we need funding. And one of the questions that came up was about local responsibility. And so the global north, the global south always whines about the global north, and yet at the same time we don't commit our own funding to science and innovation. And so I think one of the first lessons that we need to do as a global community is to get our own countries funding science. And so science is not a luxury in Africa, and I think we've discovered that. And so Amadou spoke very nicely about, you know, going where the money is, and that's the Ministry of the Treasury, the Minister of Finance. Forget about the Minister of Health. He said, don't even talk to him, go straight to where the bank is. So I agree, you know, so that I think that we have to, science is not a luxury in Africa, and we need to go where the money is, and that's what we do in South Africa. So I spend a lot of time with Treasury, telling them, don't drop my budget, drop SAMRC's budget or the NHLS's budget, but like keep mine, you know, bring it to us. So I think that's important, because I think it's important to do that. What I did, one of the take-home lessons about COVID is that we did find that the investments that we made in South Africa in HIV and TB, both at the clinical side and the laboratory side, were pivotal to allow us to do clinical research, as well as to do the laboratory assays, the virus and pseudoviruses. And also the investments we made in 2014 in HIV resistance was the platform that was used for the Omicron, and was the platform that has been used in 29 countries and supported GISAID's program. So that was an investment from the South African government. I also learned is the issue of regulatory speed. And we also heard that our regulators need to be faster. And we were very lucky in South Africa. Our regulators met us at 10 o'clock at night on Saturday and Sunday. They met us all the time to expedite the clinical trials. And there's a lot of innovations that we brought in, electronic informed consent. First time we'd ever used it. Our participants had to get Gmails. They, you know, you can imagine a Sowetan never used a smartphone, don't even have a Gmail. So we had to innovate on the informed consent processes, electronic diaries. We bought mobile phones. We worked with J&J, and they said no one's going to ever hack. These are tight. No one's going to hack these phones. It's only going to be used for the trial. And our grandmother's grandsons in Soweto hacked the phones, and they were watching Netflix. So anyway, so like, you know, there's lots of innovation that we saw. So, you know, so mobile data, we opened up a lot of opportunities just buying reading glasses. We didn't realize that, you know, people needed reading glasses, so just providing an innovation like that was important. But what we did find out when we did our vaccine trials and when we rolled out our implementation science, our vaccine, we vaccinated about 500,000 healthcare workers with the J&J. What we did find out is that we didn't know how sick our workforce was. And so when you're trying to chart to see, you know, every day you wake up and someone's had a stroke, someone's had a thromboembolic event, someone's had a DVT, someone's got Guillain-Barré. And what is the observed versus the expected side effects? And were we doing more harm than good? And, you know, we kind of, are our healthcare workers dying like flies because they're sick, or are they dying like flies because our vaccine. And so we first learned that we need data on, what is the prevalence of pulmonary embolus, DVT, stroke in our population. And that was the first thing about how important statistics was. Excess deaths are important. We're probably the only country in Africa that can give you, that we know who's born and who dies. And during COVID, we knew natural and natural deaths. We knew where people were dying. And first of all, it got us into a lot of trouble with the government, because they said that we were conjuring up mathematical deaths to make them look bad.
Oh, wow.
And that was an issue, and we were hauled in front of the Command Council and said, you are, these are mathematical deaths. People are not dying from COVID. So it's about then re-establishing the issue why excess deaths is important. But the issue is that there's not enough vital statistics that are happening in Africa. So we need to know who's born, who dies, at what age, where, and how. That's the fundamental part of pandemic preparedness, is to know if there are outbreaks of death, and that's also why hospitalization surveillance is also important, because in South Africa we had hospital surveillance that could say, if you're admitted into a public hospital, you're more likely to die. If you're black, you're more likely to die. If you have HIV, you're more likely to die. If you're in a rural province, you're more likely to die. So we knew, what the kind of natural history was. So I think that was an important thing that we had. And just quickly, in terms of what our biggest lesson learned, I'm sure Amadou also has the same thing, is our lack of manufacturing capability, our lack of being able to make biologics and vaccines. And we then got the mRNA hub in South Africa, and someone mentioned that IP and patents aren't a problem. They are a big problem. So when we got the mRNA hub, there was a discussion that Moderna or Pfizer will give you the mRNA. And no one would give us the mRNA, and we had to decode. And every step of the way to make an mRNA is patented, licensed. So we were traversing around everything has been documented. And so to try and create your own IP is a very important.
Huge challenge. We're definitely going to dive deeper into manufacturing.
And so I think I'll stop there, because I've got a lot more to say, but let me give everyone else a chance.
Yes. We will get to some of those things, but yeah, super interesting example, so much to learn from South Africa. So Andy, what about vaccine research and manufacturing? Obviously one of the big takeaways from today will be Affinity's data, which says, if you think COVID was bad, look what else could be coming. Were we surprisingly well prepared for COVID? How do you think about creating a vaccine infrastructure that could actually work for other vaccines?
Yeah, thank you. Very, very good question. And the starting point this morning with JB reminding us that at least politicians have forgotten about the pandemic, if people in this room haven't, and that there's a sense to some extent that because we've just done a pandemic, we don't need to do another one. Of course, the problem is that we're not fully in control of that. And so the pandemic, I think, is off at the moment, certainly on the political agenda. And one of the questions in my mind is, how do you change that? I mean, what should we be thinking? How should we think about it from a society perspective? Because unless we make a noise, it doesn't get onto the political agenda. And one of the thoughts there is that if you look at the threats that we see to human populations and make it a national threat, we put a lot of money into defence against military threats, which hopefully are not going to happen too regularly. But we are prepared to invest in warships and nuclear submarines and fighter jets, and that gets nowhere near to the sort of numbers. The sort of numbers that Trevor spoke about that we're spending on global health get nowhere near the costs that even one country spends on defence against that threat. So we need to start thinking about pandemics as just as much of an existential threat as we do for military conflict. So when we come to the good news, which is the always-on part, I think when you look at the clinical research in the pandemic, we have a couple of very good examples, and I think South Africa's one of them. The UK had an infrastructure embedded in most major hospitals run by the National Institute for Health Research, which meant that there were research nurses and investigators in those hospitals doing trials of diabetes and cancer drugs. And some hospitals where there were vaccine studies, but most not. And when we were developing the Oxford AstraZeneca vaccine and I needed to switch on trial sites across the UK, I could call investigators across the NHS, and 19 sites stood up within 3 weeks just by bringing in all of those expert researchers who knew how to do clinical trials. They needed a bit of training on immunization, but that's not rocket science. And then they could deliver the trials to very high quality. Similarly, in Latin America, the Bill and Melinda Gates Foundation had funded training of trial sites across Latin America. And so we went to Brazil and were able to stand up in a very short period of time trials that recruited 10,000 people in Brazil. So I think that always on there is certainly there in parts of Africa. There's very good delivery, as we're hearing in the last panel, in many countries in Africa with some expert sites. What is a much lower quantity and sometimes quality is the coordinating infrastructure amongst hospitals and academic sites, so the ability to do databases and statistics. What industry would use a CRO for, but in academic research, you have to have embedded somewhere in the academic system. And that is very, very shallow. That hub that you need for clinical research is missing in many countries in many parts of the world. But the delivery end is not as bad as I think we might make out, and I'm sure you would agree with that from a South African perspective. The manufacturing you also asked about, and I think we have come on a huge amount in thinking around manufacturing because of the pandemic. And when in Oxford we started making our vaccine, we could make 1,000 doses at a time in our facility. We then struggled to find capacity to make our phase 2 batches, and we went to Italy and managed to make them, but they couldn't make enough for phase 3. We had this huge challenge of building up just the trials capacity for manufacturing. Now, at least for viral vectors, there's huge global capacity to do that, and we can do that in many places. And RNA capacity doesn't need such big plants or numbers of staff to manufacture. So that also gives hope that can start to appear in places. And we hear about partnerships with Moderna in Kenya, for example, and here in the UK. So I think we are seeing a building of capacity in manufacturing. We're not there yet, but it does feel like there's some direction of travel. The real challenge was really highlighted this morning is that once you've built the facility, you need trained staff, you need to maintain the facility, it has to meet the ever-increasing regulatory standards, and to do that you have to be doing stuff in those facilities all the time. And so getting that model right, so that there's production throughout the period until the next pandemic of something that's useful for the population needs a lot of thought.
Yeah, that's a really, really good point. Hannah, what are your big takeaways? Do you have hope like Andy gave us, or were you still?
No, that's great. And it actually is a nice build from what Andy was just talking about around, so who's going to be, what is the demand? I feel like the conversation today has been, spent a lot of time on the sort of capacity building and the maintenance and sustainability of sites and manufacturing capacity. But what we haven't had a chance to talk a lot about is what of the delivery systems and the experience that has happened in countries can we retain as always on? So how do we build on those investments? And when I look back at sort of talking points I was given, to be honest, on the question around integration, as you know, COVAX has gotten to a place where we're continuing to support countries throughout 23 in line with the demand that's coming in and their requests as best we can. But there's also a very heavy focus on the integration of C19 into a routine program, in quotes, and again, in line with countries' priorities. And I think when you look at and start to really document the diversity of innovation that countries undertook, I think there's a lot of really important information for us to garner from that. And one of my optimistic points is we're talking about this now. There's a lot of opportunity, I think, to still document. There's still resource going into the support of the integration exercise within country. There's funding, there's interest. And, overall, I saw a number that said, 50 billion touches were made, across the pandemic. And within AMC 92, so the poorest 92 countries, we achieved amazing outcomes for targeted populations. So 85% for healthcare workers, 67%. These are primary series doses, but for the elderly. And at the same time, clearly countries were not at the start of this in a position to reach these target populations. And so I think there's a really interesting opportunity for this group and this conversation to, as I say, document and really start to support countries as they integrate C19, because that is the adult vaccine that we have right now to use. And even as that's not a top priority for everyone, I think where it is. And the other thing is just looking to see, I mean, there's a lot of reference to how do you bundle sort of adult immunization into existing, whether they're healthcare systems or programs. And there is a lot of evidence already from the innovation that the countries have been embarking on. I got information, yesterday about Cambodia and them really moving ahead with the idea of the non-communicable disease, COVID-19, doing screening and sort of offering that bundle of services. Rwanda, as an example, the information around who were the vulnerable populations was actually in the hands of the health insurance system that had been doing sort of documentation and tracking who needed to pay for health insurance and who didn't. And then through that mechanism, you actually had some of that information for the registry that you need. So how do you, again, gather that information and invest? So that, I think, is one important takeaway. And we have a time-limited opportunity to really work on that. So.
Yeah, we really do. And I wanted to go back to Glenda's point at the start, because she said very important C word was cash. Yeah. You are the resident economist on the panel. Yes. It seems like there's no one on this panel that has lots of money. And there's also no one on this panel who has lots and lots of other things they need to spend the money on. So I'm going to play the role of the Treasury Minister, who is quite concerned about the cost of living crisis and energy bills and possibly getting re-elected, and the populace is maybe not thinking so much about pandemic preparedness. So how would you convince us that we need to spend money on this pandemic that, some people said was once in a century, and so there's a whole century to go?
I guess I'm not sure we need to convince them to spend money on the pandemic necessarily.
On pandemic preparedness.
But I guess one of the big topics here is like, what's the value proposition for the always-on opportunity, which is actually how do you convince people to invest in that dual purpose, and what does that look like? And I do think there was a point earlier around how differentiated it will necessarily be across countries, which again is where sort of documenting who went via what mechanism to actually reach adults. But I do think, and this is a conversation I know John has had with also colleagues at Gavi, is just thinking through what is the cost benefit of investing in adult immunization. And if you're a country or you're a donor, as you think about that, the health benefit, when you think about it health only, it doesn't actually stand out as a good proposition. So what can you bundle again with that? And I think thinking through whether it's a package of vaccines, so healthcare workers, can you target healthcare workers and offer a set of vaccines that have really important externalities in addition to helping the recipient? Is there any way, and again, this is an idea that people have talked about, can you pull together the benefit of investing in adult immunization with the additional demand for capacity that comes with it? And is there a business model there that you could convince a finance minister that would be worth it? I mean, the trick is who's going to pay that incremental, that externality. But I think, thinking through what are we even offering them as an opportunity? Yeah.
And Glenda, what do you think? And also with the added angle that might be about convincing you to spend on your own country, but how do you convince someone to spend on the rest of the world?
So the business model is, this is how you give jobs and you generate your economy. So when we looked at our ability to make vaccines or biologics in our country, we have no manufacturing capability. And so what we had to do is we're building a manufacturing capability workforce. So we've invested 120 million rand in training everybody from quality assurance to being able to do the mRNA work or any other vaccine platform. And so if we create manufacturing capability with antivirals, monoclonal antibodies, biologics and vaccines, we can be a powerhouse. We can make, we can take the example of Big Pharma and make money. So for me, it's a no-brainer investing in pharmaceutical, in API, and in developing capability, because we'll put jobs in the workforce, we'll make our countries rich, and we'll also live longer. So that's the business case. It's an economic business case. It's about, we see the value of, of pharmaceutical companies and how much money they make. And we could do the same thing in Africa. So it's not just about South Africa, but it's about a workforce that's able and ready to respond, and in the same time, put money on the table, feeding people's mouths.
Yeah. Andy?
I was going to say, I wouldn't divorce the cost of living crisis from pandemics, because it reveals inequalities, whether that's around changes in social policy or the economics for the poorest, but also access to immunisation. We know that many of the more marginalised communities in this country had very poor access to vaccines, mistrust in the vaccines. In peacetime, that's something that we do want governments to focus on, and that is something immediately in front of them, is improving vaccine coverage for, we've had polio in sewage in London because of low uptake of vaccines in London. So we can do important bits of pandemic preparedness that are immediate issues today. I think the other thing is that perhaps with the assistance of the media, we have convinced everyone that we made vaccines very quickly, and we're really pleased with ourselves for doing that. But of course, the truth is we did the finishing line quite quickly, but there was 20 years of research on coronaviruses to get us to knowing how to make the vaccine. And if you look at viral vectors like the one we made, they've been around for 44 years. mRNA vaccines started really properly 10 years ago. So none of this was new stuff. And I think part of the message that we need to change is that for most of the diseases on Richard Hatchett's list, we actually haven't done any of that 20 years of work. We've hardly started. And that, to me, is the most worrying bit about pandemics. The finishing line bit and shortening to the 100 days is not really the issue. It's the bit that comes before that to make sure that we can go that quickly. And that message needs to get out. And can you help do that?
I do my best, Andy. So what about, obviously the other thing that was really, really highlighted during COVID was this global inequity. What about creating, I've heard you say before, Andy, that it's not really surprising that people that democratic politicians looked after their own. So what about trying to create structures where they pre-exist, that when the pathogen is flooding through, the people aren't being called upon to fund a country over the other side of the world? One thing that I've heard people mention today is the idea of like a NATO-like, you have to spend X% of your GDP on global health security. I know, Hannah, maybe you can go first, but I'll come to the others. Do you think that works?
Well, the problem is you can define health security in line with your own interests, and there is, as most people in this room know, there's a lot of political discourse right now on what would the pandemic preparedness and response, global architecture and so on look like. And that does bring up the point around sort of how do we reserve and ensure real-time supply, whether that's the manufacturers and kind of what they're willing to put on the table, but also countries that may otherwise have access to the doses ahead of time and have the money to purchase them. So there's a very dose-oriented conversation right now, I would say, or kind of access literally to vaccines, and by extension diagnostics and drugs, but mostly about vaccines. So that's a fairly response to this particular pandemic. So I think that kind of conversation could be broadened. There's not as much, it's a very health-oriented conversation right now. And so I guess the question of, I like Tony Blair, or his comment about from vertical to integrated and from children to broader populations. But I think that integration applies at so many different levels. But one of them is how do you get multi-sector conversations going where you're pooling money around something that's pretty complicated, right? It's like a health outcome and economic outcome. So I didn't really answer your question, but I think it's hard. I think
Don't
people
worry,
could
I'm
sign
used
up.
to that.
I do think that people could sign up. I think I could imagine people kind of saying this money that we are already spending, we dedicate to this effort. I don't think it'll be enough to the question of how it's allocated and how it's used will still need to be addressed. So I think something more targeted would work better.
Mm-hmm. Glenda?
Well, I think that the public purse, paid for the vaccine development and de-risked pharmaceutical companies so that they could to do that. And then the pharmaceutical companies sold back the vaccine to the governments. And so there's a lot of lack of transparency in that transaction. And if one ever had to do it again, the fact that the public purse was bankrolling Big Pharma, in the legal agreement, there must be some benefit sharing. You can't just get rich, and so maybe part of what the governments can do is make sure that there's more transparency in the contracting when you're doing this, and there's also guarantee for access. So if I give you all this money and you're going to buy Maserati afterwards, please give some, vaccine.
Which one was it that bought a Maserati?
So it's about benefit sharing. And so if the taxpayers of the world are paying for these vaccines, which they did, the American taxpayer, the British taxpayer, the European taxpayer, why on earth was there no benefit sharing? And so, so why did we de-risk Big Pharma only for them to get rich and global inequity?
And what do you think the role is of the companies in the preparedness? Like, what should they be doing? Should they be waiting till the last
I think, like with scientists, we all have to. So the only way you can do the one shot or the always on is to invest in science and to invest in pharmaceuticals. It's an important thing, whether it's in the public or the private sector. So the investment in science and investment in drug discovery and vaccine discovery and monoclonals must go on, both in the public and private sector. But when the public purse pays for things, there has to be some transparency in that contracting so that there is benefit sharing, because it's only fair. That's fairness, and we never saw that in this pandemic. We saw greed and not fairness.
Andy, what do you think about
Well, I think if you have another COVID-19 pandemic, you could write an accord where we know a lot more about manufacturing capacity, and it is better now than it was. And so that I think you could get there. The problem is that you have to war game different scenarios. So what if instead of it being a relatively innocuous pandemic, didn't feel like that, but it was a relatively innocuous pandemic, instead of having less than 1% mortality, it's 10% or 30%. There's no way that an accord would then stand in that, because elected politicians are going to focus on their populations. And I think probably people who live in those countries would want them to. But that does then create a real problem about thinking, how could you have a different setup? And the only way you can do that, I think, is having enough manufacturing capacity that wherever you are in the world, that doesn't matter if the borders get closed. And I think one of the things that we've got to really carefully think through is that isn't just about building a plant, it's about the supply chain. And we saw major disruptions to supply chain, particularly out of the US, during the pandemic. So that is a real risk for how do you make sure that even if you've built the plant, that you can then still make the products that you want to make.
Yeah, certainly. I got to know very weird little, what's going on with the shortage of bioreactor bags and all sorts of things that I've never, ever covered and hope never to cover again. Hannah, did you want to say something?
I wrote the word sustainability down a couple of times. And I guess, and one of the attractions of this conversation is that it doesn't come down to an accord in response to whatever the outbreak is, but it's ideally creating infrastructure and sort of businesses around servicing these different populations, such that your idea about pivoting and being able to reach populations that you might not otherwise. So I know the manufacturing conversation, there's been quite a lot of important discussion actually around how do you keep it warm, but not just for its sake, but in fact, and in the first instance, Gavi is thinking through with other partners, how do you sort of help direct some of the conversations around where to invest in line with where is their need for vaccines, and it may not be adults, but it might be cholera or it might be measles, and how do you encourage those who are investing in those manufacturing plants to also be thinking about where's their demand for vaccines, and so how do we make sure we're doing that? But likewise, on the health services side, I do think there's a real opportunity to try to and I keep thinking about sort of the list of case studies of what were the mechanisms leveraged, and how do you shift from it being a one-off campaign to something that you could build a workforce around and contain and maintain, and that maybe takes away from being a huge amount of money sitting with some public donors and a huge amount of money sitting with the industry at the global level to mechanisms through which you could respond. I mean, that's the ideal, I think.
Yeah, definitely. Do any of the others have ideas about sustainability in that sense?
I mean, I think it's important, the sustainability, and maybe there are two things I want to add. As I'll give you a practical example. There's this bid to take 100 days, from the time you identify a pathogen. So we're doing tech transfer for cholera vaccine, and so we know the vaccine, we know everything, and it's going to take us 2 years before we do a clinical trial. So, and this is a cholera vaccine.
2 years.
So what are the issues? What are the hurdles? So if it takes us 2 years to do a cholera vaccine, we know everything, then we need to cut corners and we have to understand it. Another thing about sustainability is there's a final C, corruption. So at a global level, we saw a huge amount of corruption around COVID, and maybe we can use that money better. And so if we had good governance around money, that money could go into good use.
Yes, definitely. And there'd be less for the reporters to write about. I don't know if everyone has just decided that it's too late in the day to ask questions, or whether my iPad isn't working. So if someone could tell me that would be great. We do like your questions if you have them. The other thing I wanted to cover, which is actually a little bit closer to what I do, is the old maxim, vaccines don't save lives, vaccinations do, that there's been issues. Oh, I did ask questions. That one of the biggest issues was we came into this pandemic where it wasn't just the lack of trust in science, it was actually a lack of trust in experts at all. And I don't feel like we regained it. What do you think the strategies are to address that? And vaccine hesitancy is the most obvious thing, but there was all sorts of disinformation, and it's only going to get worse with, deep fakes and ChatGPT coming to get us.
Yeah, so trust is a huge issue. Governments didn't trust scientists, and the community didn't trust governments or scientists. So we have a lot of work to do in that state. At this moment in time, the anti-vaxxers and the conspiracy theorists are rabid. And so we're all tired and we're not fighting. But people are getting hate mail, people commit suicide. The harassment of people who are pro-vaccine is ongoing. And so I do think that we need to address the ongoing harassment from a very well-organized anti-vaxxer campaign that persists, beyond, the vaccine mandates and rollouts. I think we have to address that. How do we protect our scientists going forward? I think that's a very important thing.
Yeah, really, really important. I was in the US at the time. It was so sad to see the number of public health officials that just resigned. They just left their posts because it was just not what they signed up for, understandably. Andy, Hannah, do you have any ideas?
Yes, I think it's so different in different countries, the experience of trust in science, and it has a political element to it, and what the politics are at the time. We've certainly, in some countries in Europe, we've had right-wing parties against vaccination before the pandemic and left-wing parties in favour, and actually arguing politically through their election process about whether they will or won't have some routine vaccines. And I think that then really polarizes a population before that happens. So there's that element. There's also very differences in the media handling in different countries. And I think we've talked before about this, that the UK, I think, is in a very different position now from 25 years ago. And one of the elements of that has been the establishment of the Science Media Centre, which is a great entity. For those who don't know, it brings together journalists and scientists to provide information about the topics of the day. And I suppose it probably also gives an opportunity for, in a safer space, for some questioning to happen on the record or off the record. And I think that has given an accessibility to health journalists and science journalists that perhaps wasn't so easy to obtain before. There are some measurable changes in reporting as a result of that. Really, it came out of the MMR and autism scandal that happened, where the now discredited story of MMR causing autism. But it really, because of that, I think has built a very different relationship between science and the media. And of course, that means with the public, because the main interface that we have with the public, apart from social media, is through the mainstream media. I was very struck here about how joined up the media was with what was happening with government policy, the reporting of the trials. It was very straightforward and much less controversial than if you look at the US media or even some of the European media. And I think that probably has meant that science is not quite as bruised here as it has been in some other countries. I don't know whether you would agree with that, but I think...
Well, I had a weird, you'd call it sort of a natural experiment or real-world evidence in that, with the N of one, that I spent March 2020 to April 21 in New York, and then the next 2 years here. So when I was so annoyed with my colleagues when I found out they had the Science Media Centre, I moved over here and I was like, this is an amazing resource. It's also very good, which, because it provides expertise with speed, which is what you need in the media. But yes, there were also very specific separate issues covering the Trump administration. For example, there were issues around, Trump saying that a drug had been FDA approved when it wasn't. Normally, if the president says that, you can take that as read. So there were very particular issues over there. Anyway, before I'm going to move on to our questions, because I want to make sure that the audience has their questions too, now that Helen has helped me work the iPad. So one is for you, Glenda. It says, you mentioned how prohibitive IP has been in South Africa and other countries. And perhaps this concept may seem abstract to those who didn't experience it. Could you tell us more about the lived experience of the affected people in the Global South? What was your experience in South Africa in the difficulty in procuring vaccines for both healthcare workers and the general public? And what timelines were there for access to the vaccines in the Global North versus the Global South?
So it was so South Africa was involved, as we heard earlier, in many of the COVID vaccine trials, and at that stage, there were two paths that were being proposed: the COVAX path and the bilateral agreements with Big Pharma. And I think African countries held out with the bilateral agreements with Big Pharma because the COVAX issue was touted to be appropriate. And I guess we got caught in the middle, in the cracks, because suddenly we didn't have COVAX and we were last in the queue for the bilaterals. And so South Africa was scrambling around trying to find big borrow and steal vaccines from everybody. And that was a big issue. And then we had the issue with an underpowered study in the wrong population that didn't help us understand the efficacy against the beta variant at that stage, which made the country very nervous to use the AstraZeneca, which we had procured.
Although the science was clear, but when it...
Yeah, we didn't have the data, but it was data-driven, and so we had to switch very quickly to the J&J vaccine, which we managed to get a donation to give 500,000 healthcare workers the vaccine. And so really there was, there was a feeling that the government had mucked up, and we had been let down by both COVAX and our lack of negotiation with the bilaterals, and the cost of goods. So there's also a lack of transparency when you're having these bilaterals with Big Pharma. Everything is secret, and you don't know what. We could have paid actually more for the vaccine than the USA for all we knew, because we didn't know. They were very secret and non-transparent. So I think we need transparency in the negotiations, the bilaterals. We shouldn't put all our eggs in one basket, and that's why we fell through the cracks. And the COVAX came, but it came so late in the day for the countries that needed it, at a stage when already the need had dissipated. But for South Africa, we had one of the highest fatality rates, and so we did not escape the pandemic. We had excess deaths that surpassed HIV and TB. We had life expectancy that changed. We ran out of oxygen. We didn't have enough nurses. We had to stop alcohol and curfews to try and keep emergency beds open, so we could open up beds for people with who had COVID. So we had a devastating impact in South Africa. It was brutal, and so South Africa did not escape it. And we saw whether you were the rural poor, HIV infected. We saw a huge catastrophe in our country around that, and no one was spared. And healthcare workers did have to go out and navigate this with inadequate PPE and without vaccine coverage. So it was quite brutal, our experience of COVID.
Well, thank you for sharing that with us, and thanks for the question, because I think it is important to remember. It seems so quickly that people forget. Sorry.
I was going to say on the IP issue that I'm probably more in Linda's camp when she said earlier on that it's a bit of a distraction, and I think from the IP sharing, IP waivers have worked very well with some drugs, but these are relatively easy products to manufacture. If you're a vaccine developer making a biological product, if you then essentially share your recipe with someone else, which is what would happen over an IP waiver, you then have no control over the way that it's being made. And these are difficult to make. And of course, for Big Pharma, that's then a risk for them that someone's going to make their product and it not be the same or the same quality or safe. So I think that there are some reasons why Big Pharma is very concerned about that. And the different model that we took with AstraZeneca was to, rather than waive IP, to set up 20 manufacturing sites where they were then supported to manufacture. And so you then maintain the oversight of the quality of the product, but you still have that distributed network. And so that's just one example of how you might do it, where you've got Big Pharma worried about waiving IP. So I think it's different when you're dealing with drugs, and maybe because mRNA is much more like a chemical process, that might be an easier way for particularly in a low resource setting to waive IP.
Can I say, so what happens with in territories, so obviously when you have a new drug or a new vaccine platform or something, is that, or a new antibiotic, is that you register your patent in certain territories. And unfortunately, South Africa is one of those places where Big Pharma always registers their patents, which then restricts our ability to deliver the mechanism. Not having access to IP wastes time. So we wasted time with the mRNA hub. It would not have hurt Moderna or Pfizer to assist the WHO mRNA hub and allow us to, instead of allowing us to decode, and maybe it's better that we decoded it because now we're cleverer and have new things. And we're looking on different platforms. We're looking at green vaccines, not using mammalian cells, looking at things like tobacco, using tobacco plants and other green technology that are cheaper, scalable, and don't have the cold chain issues.
Yeah, it does seem like this is one of the big unsolved battles from the pandemic. It will be hard to Hannah, did you?
I guess the only thing I would add to that, and it refers more to this issue around what kind of investments are we making in manufacturer capacity and for what going forward. I mean, the situation you described, I don't know if your access to vaccines literally in the months when you didn't have them would have been changed had there been a waiver on the IP. But the question and your point around sort of who's partnering to accelerate the diversification of capacity and know-how, how to make technologies, that's with an eye to, I think, going forward and a different way of approaching it. So I think the tricky thing around IP at the moment at which it was really being called for waivers and sort of that, it was almost, for that problem, it was too late at that point. And it's not clear it would have been the solution had it not been, but at that point, it wasn't going to be enough to change what were other drivers of the access challenge. But so I do think as we think through the diversification and manufacturing question and the role of the partners and sort of what role do the multinational pharmaceutical companies get brought to the table to and help with, because I think that I agree with you that the hub sort of model being almost isolated from what else was going on, made it almost like a sideshow, but not a serious venture, when it could have moved a lot quicker. So.
There's another question come in, which I think is going to be a nice one to sort of bring our discussion to a close, because it is about this always on theme. I'm going to punt this to Hannah first, but the others might have thoughts on it. It says, is there any way to pivot infrastructure that will be built for NCDs, so non-communicable diseases, to pandemics? So basically the point is that in many developing countries, the non-communicable disease burden is rising. They will have to build infrastructure. Can that go to pandemics or vice versa? Hannah, do you want to?
I mean, I think the easy answer to that is just the reality that the people who have non-communicable diseases tend also to be, at least in this particular instance, we're also the higher priority populations. And so to the degree, at least on the healthcare system side, as opposed to the product development side, although clearly they're related, because the more you can address the appropriability issue that came up in the panel earlier that Linda spoke to, but the more you're working towards technologies that are more affordable, but also more in line with what's usable, you also have more people come in. But I think it's building the healthcare force and the touch points with populations that then in turn, I think, makes it available to pivot more easily than at the moment. There's just not a lot of accessing of healthcare by these populations.
Can I add? I think the NCD place is the right place, because we talk about adult vaccination. Yeah. So adults have got diabetes and they've got hypertension, and they need to go to the clinic every 3 months or every 6 months to be seen. And so theoretically, an adult vaccination program does exist. We must pivot the NCD model, the family planning model. People come and get their depot, their injectable contraception. So that is, there is an adult vaccination platform in NCDs and in family planning and in the school-based HPV program. So they do exist, these adult, we just have to pivot the experience. So when you get your antihypertensive and your anti-diabetic drug, you get your shot as well. And I think that we should just make sure that we're optimizing NCD management adequately, particularly in low middle income country settings.
Yeah, I think in the NCD space gives the opportunity to build clinical research capacity, and so if you embed that within the system, then that, just as here in the UK we could pivot those teams to work on vaccines when a pandemic came, you're building research capability, so it's a good thing. I think one thing we haven't really touched on in this panel is there's another big gap which you mentioned earlier on, which is around the laboratory capacity. That is far behind the clinical research capacity anywhere in the world. Even in high-income countries, we have much less research capacity in laboratories to properly, under strict regulatory control, store serum samples, samples of white blood cells, which is the relatively few places that do that in Africa. So I think that is an area where there's lots of work that still needs to be done to do something which sounds simple if you're working in an academic environment, but it's actually very difficult to put out more widely. And then the third bit, which is when you get to the clinical endpoints, the efficacy endpoints, having the capability to make the diagnosis. And particularly if you're trying to do very large-scale trials in a resource-limited setting, you'll find that many hospitals have no microbiology laboratory. And so you can't even capture the simplest microbiological outcomes from that. And that's true in Africa, it's true in South Asia as well. So I think that's the other thing. There's a lot of just the health system strengthening is a key part of being able to be on.
I think you've all made a really great case for that, and I think that you've done a great job today of bringing together what has been a day of actually a lot of the ideas that Tony Blair set out at the beginning. He said that our ideas had to be ambitious but not impossible. So I think you've had a lot of great answers, lessons learned from things that we did right during the COVID-19 pandemic and plenty that we did wrong. I mean, we'll learn about giving phones to people and how they could be hacked for Netflix and maybe some questions about IP as well. But I just want to thank you all for helping us bring today to a close. Thank everyone else for a wonderful day of idea sharing, and I think that there were many calls to action, but the two that really stand out for us is that we have to, work out how to get the cash to fund these really ambitious and impossible, but not impossible, programs, and work out how to communicate that the COVID pandemic is not, sadly, the end of all pandemics. Thank you.
Thank you.
Thank you.
Thanks.
Well, that was good.
Thank you.